Hi everyone and welcome. My name is Prayash Chaudhary and I am a PhD candidate with BCEPS at the University of Bergen. My research is primarily focused on evaluating the value of drug interventions in the field of addiction medicine. In today's presentation, I will be talking about health outcomes in economic evaluation. There are different types of economic evaluation, such as cost-benefit analysis and cost-effectiveness analysis. These analyses measure outcomes in different units of measurement. For example, cost-benefit analysis measures outcome in terms of monetary unit, while cost-effectiveness and cost-utility analysis measures outcome in terms of health effects. And in this presentation, we will focus on cost-effectiveness and cost-utility analysis. The health effects measured in cost-effectiveness analysis can be in terms of intermediate outcome measures, such as changes in blood pressure or changes in cholesterol level, or can be in terms of final outcome measures, such as survival and disease incidences. Let's look at examples of these health outcomes used in cost-effectiveness analysis. In this slide, we can see an example of intermediate outcome measure. Let's assume that there are two interventions for stroke. One reduces cholesterol level, while the other reduces blood pressure level. One of the drawbacks of using intermediate outcome measures, like in our example, is that it becomes difficult to conclude which measure is better than the other. It becomes even harder to determine which intervention produces better health benefit across different disease groups. The other health effect in cost-effectiveness analysis is life years, which is the number of years a person lives. In our example here, let's assume patient after a stroke on average lives 10 years with the standard of care, while with a new intervention is expected to live 12 years. In a glance, it seems that the new intervention is better since it improves the survival of stroke patients. One of the drawbacks of using life years as outcome measure is that it only considers the quantity of life and does not include the quality of life. Therefore, in cost-utility analysis, we use outcome measures such as QALYs, quality adjusted life years, and disability adjusted life years, which incorporates both quality and quantity of life. Now, let's look at these two outcome measures in detail. Disability adjusted life years. Disability adjusted life years combines two components: years of life lost and years lived with disability. Let's look at these two components in further detail. Years of life lost is life expectancy at the age of death minus the age at death, while years lived with disability is life years a person live in a particular with a particular disease or disability multiplied by the disability weight assigned to that disease. These disability weights are measured between 0 and 1, where 0 reflects no disability or full health, while 1 reflects a health state which is considered equivalent to death. Let's look at daily calculation with an example. Let's assume there is a patient who lives for 65 years and at the age of 65 suffers from a stroke event. The person continues to live for next 5 years, however, with continuous complications from the stroke event that occurred at 65 and dies at the age of 70. In our analysis, or in this example, we assume that the average life expectancy of people at the age of 70 is 78 years. And we assume a disability weight for stroke is equals to 0.316. Thus, let's calculate the two components of disability adjusted life years. The years of life lost is then life expectancy at the age of 70, which is 78, minus the age at death, 70. the years lived with disability is the 5 years lived with stroke multiplied by the disability weight assigned to stroke, thus giving us a 9.58 disability adjusted life years, which can be interpreted as that the person lost about 9.58 disability adjusted life years due to stroke. Let's look at QALYs now. Quality adjusted life years incorporates both the impact on the quantity and the quality of life. QALYs can be calculated by multiplying life years lived in a specific health state with health-related quality of life or the utility value assigned to that particular health state. Utility value is measured between 0 and 1, where 0 reflects a health state equivalent to death and 1 reflects full health. Both utility values and disability weights are measured between 0 and 1, but the way it reflects the health state is totally opposite. Let's look at QALY with an example. Let's assume a person lives for 10 years in a health state A with utility of 0.75, giving us 7.5 quality adjusted life years. Let's assume a different person lives for 12 years in health state B with utility of 0.6, giving us 7.2 QALYs. This example shows that living more years does not necessarily mean that you will have higher quality or higher quality of life, as the quality of life could be very poor during the years of survival. Now we talked about health state and utility value, but how do you derive this? How do you get this health state and this utility value? These health state and utility values can be defined and quantified using generic tools such as EQ5D questionnaire, which reflects how the general population perceives the quality of life to be in a particular health state. Let's look at the EQ5D tool in more detail. EQ5D tool consists of two main components: the VAS, the visual analog scale, and descriptive EQ5D questionnaire. A visual analog scale is a thermometer-like scale with fixed endpoints between 0 and 100. 0 reflects the worst imaginable health state, while 100 reflects the best imaginable health state. One can mark a score on the scale, which then reflects how good or bad a person perceives their health to be in that particular day. In this example, let's say someone marks 70 as their score. This score reflects that individual's preference of being in their current health state at that instance of time. In order to define a health state in numerical value and assign preference-based utility value derived from the general population, we can use the descriptive system of EQ5D tool, which is the EQ5D questionnaire. This is a version of EQ5D tool which includes 5 dimensions and 5 labels of severity for each dimension. The 5 dimensions included in this questionnaire includes mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. Each dimension then have 5 labels which reflects different level of severity. These levels of severity are then scored between 1 and 5, where 1 reflects no problem and 5 reflects the most severe condition. Let's look at an example of how we can derive health state and utility value using this questionnaire. Let's imagine someone fills out this questionnaire, and in our example, let's say the participant has slight problem in walking, moderate problem with self-care, slight problem with usual activities, severe pain and discomfort, and is extremely anxious or depressed. When these responses are scored between 1 and 5, this gives us a numerical value to describe the particular health state an individual is in. In this example, 2, 3, 2, 4, 5. Using different elicitation methods such as time trade-off and standard gambling, researchers have tried to understand and value the disutility of being in different levels of severity in these 5 dimensions of quality of life. Once the health state is described, then the corresponding disutility of being in that health state can be subtracted from 1, which reflects a full health, thus giving us a health specific utility value for being in that particular health state. This utility value then can be combined with the life years to obtain quality adjusted life years. A final key message from this presentation is that the health outcome measure in economic evaluation should be able to compare changes across disease and intervention. This will allow the policymakers to choose the most cost-effective interventions across different disease groups while setting priority in healthcare. Thank you.